In this presentation, we'll be discussing some common neurological complaints that you'll see in primary care, including tremor and dizziness. The lecture was written by Kim Myers, a board-certified nurse practitioner with a specialty focus in neurology. She currently practices at a neurology office in Dayton, Ohio. The lecture is narrated by Dr. Tracy Murray. In this lecture, we're going to discuss two very common neurological complaints that you'll see in primary care, starting with tremors. Tremors are involuntary and rhythmic movements of the body or limbs occurring in isolation or as part of a clinical syndrome. In clinical practice, characterization of the tremor is important to determine the etiology and treatment. Therefore, a thorough history and physical exam are very important. Let's begin with a short case study. James Smith, a 67-year-old gentleman with a history of diabetes, COPD, depression, and hypertension, presents to the office with handshaking. His wife accompanies him to the appointment. Vitals are 142/76, heart rate 84, respiratory rate 24, SpO2 91% on room air. The weight is stable. Medication list is reviewed. He's on metformin 1,000 milligrams twice daily, lisinopril 20 milligrams daily, Symbicort 2 puffs twice daily, albuterol 2 puffs QID PRN, and Zoloft 50 milligrams daily. Mr. Smith describes handshaking more noticeable on the right than the left. There have been no new medications added, but he has been using his inhaler a bit more often. What other history would you like to know? Let's start with the old cards. In response to your questioning, Mr. Smith answers the following. The onset was a few months ago. He notices it in his hands, but his wife says his head bobs sometimes too. The shaking is intermittent, but it does happen more frequently. It's characterized by both hands shaking when he's holding his arms out. He says it's worse writing out checks or when he's holding a plate. Some aggravating factors include reaching for things or holding things in his hands. Relieving factors seem to be when his hands are relaxed in his laps, the tremor or shaking is reduced. He's tried no treatments, and the severity of it doesn't hurt, but it's embarrassing. So there are three general categories of tremors. There's the resting tremor, postural tremor, intention, or kinetic tremor. I'll discuss these individually and give you some examples of each, and then we'll look at the history examination and differential diagnosis. Resting tremor occurs when a body is at complete rest against gravity or sitting still with arms resting in the lap. The most common conditions that are associated with resting tremor are Parkinson's disease and medication tremors. Parkinson's disease is a progressive neurological disorder with 4 hallmark signs: a resting tremor, cogwheel rigidity, bradykinesia, and postural instability. Other characteristics include the following: facial masking, difficulty standing from a chair, a tendency to freeze when initiating movement or ambulating, a festinating gait. This is a gait that's quick, short stride with head down and flexed at the waist. It may appear that the patient cannot stop themselves and may fall forward. Reduced arm swing on the affected side, and short, shuffling strides that require multiple steps to turn. The resting tremor associated with Parkinson's disease is often asymmetric, involving the upper extremities. It can also involve the lower extremities or the tongue. Parkinson's disease is an entire lecture in itself and is discussed more in depth in NR 601. So what you should extrapolate from this lecture is that Parkinson's disease is associated with resting tremor. Keep in mind that there is a group of Parkinsonian syndromes that present similarly: progressive supranuclear palsy, multiple system atrophy, and vascular or ischemic Parkinson's disease. Now, resting tremors may also be medication-induced. Certain medications can cause extrapyramidal side effects similar to Parkinson's disease. Antipsychotics are the most common offending agent. Metoclopramide or Reglan and phenothiazines such as compazine can also cause Parkinsonian features, including a resting tremor. Wilson's disease is another condition that's associated with resting tremor. This is a very rare genetic disorder associated with copper toxicity. Patients who are affected may have extrapyramidal symptoms similar to Parkinson's with a slow and progressive course. There may be symptoms of incoordination in the hands, dysarthria, and gait disorder, bradykinesia, rigidity, and ophthalmological changes. The workup for Wilson's includes serum, ceruloplasmin, and copper. Diagnosis is confirmed with liver biopsy, which identifies the copper toxicity, and treatment is aimed at lowering copper levels. The next category of tremors is postural tremors. Postural tremor can be seen when the patient is asked to extend their arms in front of them. The most common type would be an essential tremor. This is the most common form of all movement disorders. This tremor is seen in the hands and at times the head, and there are cases when the voice may be involved. The tremor is bilateral and generally symmetric. There is often a positive family history or similar tremor, and drinking alcohol often reduces it. Postural tremors can also be medication-induced. Signs and symptoms of drug-induced tremors depend on the drug used and the patient's predisposition to its side effects. Medications such as steroids, caffeine, anti-epileptics, antidepressants, and asthma medications may cause a postural tremor. Eliminating the offending agent is often the treatment of choice. Finally, the third type of tremor that we're going to discuss is the intention or kinetic tremor. This type of tremor is characterized by an increase in amplitude when the patient attempts a voluntary movement. It can be assessed by having the patient perform the finger to nose movement. Intention tremor may be associated with medications, alcohol or drug abuse, multiple sclerosis, stroke, or a mass affecting the cerebellum. Because intention tremor is a symptom of one of these disorders, it cannot be treated. Coping mechanisms such as occupational therapy can be offered. The history should assess the tremor's characteristics including onset, duration, severity, affected area, progression, alleviating and relieving factors, effect of alcohol, family history, associated symptoms, and prescription, herbal, and over-the-counter medication. Now, let's get back to our case study. We have added a few specific details from the questions above. Mr. Smith says that his grandmother had a head tremor. The patient has noticed the tremor is worse when he's in a hurry or anxious. He doesn't notice it much on Saturday or Sunday when he has a beer or two watching football games. His tremor may be worse after using his inhaler. Now that we have a complete history, we still need to complete a physical exam to help with the differential diagnosis. The exam should include an evaluation of the tremor at rest, when assuming various positions, and when moving. It's also important to note if the tremor is present with rest or activity, the affected part of the body, and laterality. An examination of gait, muscle tone, facial expressions, and posture should be assessed. A complete musculoskeletal and neurological examination should be done to assess range of motion, mental status, strength, sensation, cranial nerve function, and deep tendon reflexes. Upon exam, Mr. Smith extends his arms and reveals a high-frequency postural tremor in both arms. There's no evidence of a head tremor during the exam. Gait testing is unrevealing. There is no cogwheeling. Muscle tone is within normal limits. And coordination and cerebellar testing is unrelieving. So does the history and physical exam provide enough information to classify Mr. Smith's tremor? Let's consider the possible differential diagnoses. Based on our history and physical, are these diagnoses probable, possible, unlikely, or unclear? So we'll start with benign essential tremors. This is at the top of the list because it's more probable. He has a positive family history, and the tremors reduce with alcohol ingestion. Metabolic imbalances are possible, but we do need further lab studies. The effects of drugs or caffeine are also possible. He's taking an SSRI and uses albuterol, both of which can contribute to the tremor. Panic and anxiety attacks are possible as the tremor intensifies when the patient is anxious. Alcohol withdrawal is unlikely based on the current information, as is a cerebellar lesion based on his neurological exam. Multiple sclerosis is unlikely based on patient's age and presentation. And Parkinson's disease is possible but unlikely based on today's exam. I'd caution you as a clinician, though, not to remove Parkinson's disease completely from your differential, even when a more likely etiology has been identified. In my experience, a patient can present with benign essential tremor and then later transition to Parkinson's disease. To rule out systemic causes of tremor, basic laboratory tests should be ordered. Thyroid function tests should be done to rule out hyperthyroidism, as well as a CMP to rule out hypoglycemia, electrolyte imbalance, and liver disease. Additional testing may be considered based on the suspected etiology. For example, an MRI would be indicated if patient exhibited cerebellar dysfunction during the examination. Treatment of the tremor is based on the etiology and significance of symptoms. For example, treatment of essential tremor is based on whether the symptoms bother the patient or not. Treatment usually begins with primidone or mycilline, a beta blocker, or a benzodiazepine. Dosages are gradually increased to achieve optimal response. If monotherapy is ineffective, a neurology referral is appropriate. If the tremor is medication-induced, that agent may be reduced or eliminated if possible. Parkinson's disease may be treated with a dopamine agonist or dopamine replacement. Neurology may initiate combination therapy or use other pharmacologics that are not labeled for the treatment of tremor. If pharmacological therapy has been ineffective, localized Botox injections may be considered, and deep brain stimulation can also be considered in severe cases. Okay, so now let's move on to our next topic, which is dizziness and vertigo. Before we start, it's important to understand the difference between the two terms, as they are often used synonymously but are quite different. Dizziness is a sensation of instability when walking, or unsteadiness. It can be described as a feeling of lightheadedness, weakness, or feeling faint. Vertigo, on the other hand, is the sensation of rotation or movement of the patient or their surroundings. As it is with most neurological disorders, obtaining a detailed history is key. Primary care patients often describe their chief complaint as dizziness, but as part of the history, you need to understand what they mean. There are some patients who say that they feel dizzy, and it refers to their sense of internal or external motion. Others may say they are dizzy but mean they feel off balance, whereas other groups will feel faint or lightheaded. I often ask my patients to describe their symptoms without using the word dizziness. Developing the differential starts once the patient explains and you understand their symptoms. I have three broad categories for terms associated with dizziness that I use to establish in what the patient means. Vertigo, a sense of internal or external motion. Lightheadedness, or feeling faint. And imbalance, or instability. Once we can classify the type of dizziness that they're referring to, obtaining a good HPI is essential. Specific HPI questions would include the following. When did the symptoms first occur? Did the symptoms come on suddenly or gradually? Have they had similar symptoms before? Are the symptoms constant or episodic? If episodic, how long does each episode last? Description of the complaint, such as lightheaded versus room spinning. Any changes in walking or balance? Are there any activities that trigger or exacerbate your symptoms? What alleviates the symptoms? Have you tried anything to make it better? And how does this affect your ability to work or perform daily functions? In the review of systems, it's important to know if there are any accompanying systems such as the following: syncope, nausea and vomiting, hearing loss, weakness, tinnitus, headache, paresthesias, visual changes, changes in walking or balance, falls, and loss of consciousness. Finally, don't forget to ask if there have been any new medications, illness, or trauma prior to the onset of symptoms. Reviewing family medical history as well as complete review of systems will help guide us through the diagnostic process. Previous diagnostic testing should be reviewed as well. I often find that the patient history is almost enough to make a diagnosis without a physical exam. Before we move on to diagnosing the cause of dizziness, let's take a moment to consider the potential anatomic causes. The brain perceives balance through the CNS system by processing information provided by the eyes, inner ear, and peripheral nervous system. A disruption in any of these anatomical areas can produce symptoms of dizziness. Patients may also complain of dizziness that stems from systemic causes such as anemia, cardiovascular disease, hyperventilation, drug reactions, endocrine disorders, fluid and electrolyte imbalances, and psychiatric problems. By understanding these concepts, we can then determine our differential diagnosis. The differential diagnosis for dizziness can be classified into three separate categories: peripheral, vestibular disease, CNS disorders, and systemic disorders. Peripheral vestibular disease accounts for 40 to 50% of all cases of vertigo and dizziness. This class falls into my vertigo category, which is where the patient reports a feeling of internal or external movement. For example, the patient might say, "When I sit up, the room feels like it's spinning around me." Peripheral vertigo occurs when there is dysfunction of the vestibular nerve or in the labyrinth of the middle ear, which is the semicircular canals and cochlea. Potential etiologies could include inner ear inflammation or infection, tumor, or otoliths, which are small calcium particles in the labyrinth. There are three types of peripheral vestibular disease, which includes benign positional postural vertigo, labyrinthitis, and vestibular neuritis. Benign paroxysmal peripheral vertigo will be covered in a different lecture, but the condition is often benign and self-limiting. Right now, I'll just touch on peripheral vertigo in terms of non-BPPV situations. Vestibular neuritis is a disorder resulting from an infection that inflames the inner ear or the nerves connecting the inner ear to the brain. This inflammation disrupts the transmission of sensory information from the ear to the brain. Symptoms are usually acute in onset and will resolve within days and also tend to worsen with movements. Symptoms can be mild or severe, ranging from subtle dizziness to a violent spinning sensation. They can also include nausea, vomiting, unsteadiness, imbalance, difficulty with vision, and impaired concentration. There is no hearing loss or tinnitus. Nystagmus is often seen on exam. In labyrinthitis, a production of the same symptoms as vestibular neuritis occurs, but the patient will complain of tinnitus and/or hearing loss. Hearing loss may be associated with labyrinthitis, but not vestibular neuritis. No specific test exists to diagnose vestibular neuritis or labyrinthitis. Therefore, a process of elimination is often necessary to diagnose the condition. The differentiating symptom between the two conditions is hearing. Labyrinthitis can affect hearing, whereas neuritis does not. The next ideological category for dizziness are CNS disorders. CNS disorders that disrupt the pathway between the vestibular apparatus and the brain can cause central vertigo or dizziness. Acute onset of symptoms can occur from injury to the brainstem or the cerebellum. Common etiologies would include stroke, TIA, vertebrobasilar insufficiency, basilar migraine, cerebellar hemorrhage, and the onset of multiple sclerosis. Central vertigo can be accompanied by brainstem symptoms such as blurred vision, double vision, numbness, weakness, loss of balance, slurred speech, swallowing problems, hoarseness, and Horner syndrome. In the primary care setting, patients with acute vertigo accompanied by headache and brainstem symptoms should be immediately sent to the ER to rule out stroke or hemorrhage. Symptoms that have been present for days and without neurological impairment should undergo further workup with an MRI. Systemic disorders can cause dizziness or a feeling of lightheadedness that may be accompanied by presyncope. Systemic disorders causes can include hyperventilation, such as during a panic attack, orthostatic hypotension, vasovagal or neurocardiogenic syncope, or hypoglycemia. Arrhythmias, aortic stenosis, and hypertrophic obstructive cardiomyopathy should also be considered. Symptoms such as blurred or tunneled vision, palpitations, diaphoresis, pallor, dyspnea, tachycardia, bounding pulse, weakness, hypotension, decreased breath sounds, headache, diaphoresis, nausea, and agitation should prompt you to look for systemic causes. Dizziness that would be better described as a sense of instability or loss of balance can occur in the setting of the visual dysfunction. Examples include but are not limited to diplopia and corneal or retinal diseases that result in asymmetrical visual input. Instability can also occur in the setting of proprioceptive dysfunction. A common example would be diabetic peripheral polyneuropathy. Spinal cord disease such as metabolic myelopathy from vitamin B12 or copper deficiency could also produce a sense of disequilibrium from the loss of proprioception. When performing a physical exam on a patient who complains of dizziness, one has to be cautious and perform the exam with the intent to rule out possibilities as opposed to ruling a suspected cause in. Key points of the physical exam include vital signs, orthostatic vitals, cardiovascular auscultation, assess balance with Romberg test, the gait including tandem gait, check for dysmetria, dysdiadochokinesis, and ataxia. Briefly assess the hearing and examine the tympanic membranes for wax, perforation, and infection. Check extraocular movements for evidence of nystagmus. You may also perform a Dix-Hallpike position test. Exams should also include deep tendon reflexes, vibratory sense, pinprick, and proprioception. And diagnostic testing would depend on the differential and type of dizziness as ascertained from the history. Testing that may need to be considered includes MRI of the brain, EKG, echocardiogram, tilt table, spinal imaging, hearing evaluation, or referral to a specialist based on the condition suspected, such as ENT, neurology, and cardiology.